Good evening, namaskar, everyone. Once again, a very, very warm welcome to our monthly learning series, SAFE. And this is being hosted by ANEI Patient Safety Fellows. Very happy to, welcome all of you. Just give me 1 second. I will do a little bit of introduction before. Just give me 1 second. My presentation seems to have disappeared. Just give me a minute. Okay, here we are. SAFE stands for Safety Awareness for Excellence, and this is hosted by our ANEI Patient Safety Fellows. So before we start the session, I would, play the anthem and we all stand for 2-3 minutes. Yes. Oh, does not seem to be working. Yeah, I need to enable the content. Now it should be working, I guess.
We are the voice, the hands that care, guardians of hope, always there. With wisdom and courage, we stand tall, answering the call, serving all. In every moment, through joy and strife, we lead with purpose, we honor life, building the future with knowledge and grace, transforming healthcare in every space. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. Together we rise, united we lead, planting the seeds for a brighter tomorrow. Together we rise, united we lead, planting the seeds for a brighter tomorrow. ANEI, nurses make the difference to humanity, shaping the future with strength and unity. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. We are ANEI, proud in all we do.
Thank you, everyone. And we move on. And this anthem was, inaugurated, launched during Anicon this year, May 2025. And we invite all of you to join the association if you are keen on sharing and caring for the profession. So, if you are not an ANI member, you're welcome to join. You can visit our website www.anei.in and you can join from there. So, as I told you, the safe learning sessions are brought to you by ANI Patient Safety Fellows. And this ANI Patient Safety Fellowship program is, you know, done in collaboration with the Patient Safety Movement Foundation USA. And we have had, already four, and we are hoping the fifth cohort applications are being invited, and this is open to only any members. And by end of August we will be looking at the applications, and then there will be a round of interview, and then we will be inducting the new fellows. So we really hope those who are passionate about patient safety, those who want to learn more and do something different in their organization to ensure safety, safe care, please do join the fellowship program. But before that, you need to be an ANI member. In case anybody has any questions, you can always reach out to me. I can explain to you. And these kind of learning sessions have been held from the very first year, and every year we do that monthly sessions, and they are held without fail. And our fellows have been very disciplined to ensure that everything is done as planned. And they also do quality improvement projects every year. So it is a 2 year fellowship program. The first year, 6 months are spent in learning, understanding the WHO patient safety curriculum, and the following 6 months are spent on a quality improvement project or any other assignment, and that is decided by the team. And then in September, they present the project in the presence of Dr. Michael Ramsey, who is the CEO of Patient Safety Movement Foundation. And this year also, Sir is going to join us on 19th September at Guwahati, AIMS Guwahati. He'll be, joining virtually. And you can imagine it's usually where he's from Dallas, and their time is around 2 a.m. And he's a very senior person. And so I feel very bad, but then so willingly he always says, I want to be there because he want to see what the projects have been done by the fellows. And so far he had been very encouraging, and this year he has given permission to increase the number of seats to 15. But we are still waiting for good number of applications. It's not yet true. We just hope that people are interested, but they should start applying now because we want to make sure the screening is done, the interviews are completed, and then we are able to announce the cohort five's names on 19th of September. So please join us and contribute to improving patient safety. And we have fellows here in the audience, and there are three cohorts have already been, passed out. So there are many. So I can put you in touch with any one of them so that you can understand how this program is it valuable, is it good to do this fellowship. And you do get a certificate at the end of 2 years. And the people who get certificate this September, cohort 3, they actually get a graduation ceremony during Anicon next year. So they attend, and they actually graduate from the program. So with that, we are in August, and we are going to hear Miss Margaret Gowrinath. She's the ANI Patient Safety Fellow 2024-26. She's going to discuss with reducing alarm fatigue, and I'll not talk more on that. She will be introducing the topic, and she will be discussing. Coming September, we have Miss Nitu presenting reducing hospital acquired pressure injury. This was a project that she had presented last year. During the conference, they just get about 7 minutes to showcase their project. So they now we have given them an opportunity to take an hour and explain the project. And when you join these, you also get to see that how they are doing the project and what are the results. So today it's my privilege and honor, and I'm very happy to invite Margaret to talk about reducing alarm fatigue. And in September, you will see Nitu, who will be talking about reducing happy hospital acquired pressure injury. And once again, inviting all of you to join us for the our fifth annual Patient Safety Conference in collaboration with AIMS Guwahati on 19th of September. And the theme is as given by the WHO towards zero harm. That is our theme every year, safety from the first, safe care for every newborn and every child. So that is the topic that is given by WHO. So with that, thank you everyone for being here. We have more than 50 people already. That really shows the eagerness for everyone to learn and hopefully champion the cause of patient safety. Margaret, can you please come on the video and please start your session? A very, very warm welcome, Margaret. And she is doing her fellowship, but at this moment she is sitting in Africa, correct?
Yes, ma'am.
Okay, okay. Great. And they all will be doing their projects also, correct? You'll be
Yes, ma'am.
starting on 19th. So I'm doing a little bit of marketing here to get more fellows to apply, right? So thoda hatke. So over to you, Margaret, and you can take up to 8 p.m. and then we spend another 5-10 minutes if required. Then we
Okay,
take
ma'am.
questions, and when you have questions, please put them in the chat box, and we will answer all the questions. Yeah. Okay. Thank you, Margaret. You can share.
Good evening, ma'am, and good evening to everybody over here. It's always a great honor to speak in front of our own fraternity. And it's a great honor today to present as a patient safety fellow. As madam is saying that she is advocating, I don't think she needs to advocate. We are all here live, evidence-based members here that our seniors have graduated. Our mentors, 1 year senior to us, are our mentors, and they are mentoring us in the project. And whether the outcome is excellent or better or best, but the journey is so beautiful. We are learning so many things. It never is satisfying that yes, we have become leaders in the industry, so this is it. No, this is bringing us back to student period, and being a student is always very enthusiastic and encouraging and full of fun. So though we are all individuals at our own place, but nevertheless doing this project is like really fun, and I cannot explain unless and until you go through it yourself. Overcoming the challenges is great. And because I'm a fellow, I got this opportunity to speak in this a safe platform. And it's such a great honor that you as a safety advocate are being presented to speak on certain topics. So here I am, greatly honored. Thank you once again to ma'am, to the people who have selected me in this fellowship, and to ANEI at large. Thanks to the office bearers, everybody, for this opportunity, and to my own mentors and my friends. So with that, I would like to start. My topic is, reducing alarm fatigue. Now, alarm fatigue, all of you know, has got various names. Is somebody calls it, sensory alarm. Someone calls it as, it has got so many synonyms. It is also called the warning exhaustion, and like that, there are various synonyms. But today, the topic is reducing alarm fatigue, and basically a nursing perspective. How does the nursing affect by this alarm fatigue? Now, the introduction is, in the high stress environment of the ICU, nurses are tasked with managing multiple patients simultaneously, all of whom require constant monitoring and care. Amid this demanding atmosphere, alarm fatigue has emerged as a significant challenge faced by these healthcare professionals. Alarm fatigue is defined as the desensitization and eventual disregard of alarms due to the sheer volume and frequency of false and non-actionable alarms. This phenomena can have severe consequences, including delayed or missed responses to critical patient alarms, resulting in patient harm or even death. This introduction is taken by a study done by Mr. Gopal Singh Charan, and this is published in the Muller Journal of Medical Sciences in the year 23 month Jan to June. So I thought this is the apt introduction for the topic. Now, in this presentation, what are we going to orient ourselves to? We will orient ourselves to the concept, to the impact the alarm fatigue has on patient safety, to a few evidence-based practices and how to manage the alarms, and aims to enhance patient care, to improve nursing efficiency, and to reduce risk associated with mixed alarms. Now, moving over, the first topic would be understanding alarm fatigue. What exactly is alarm fatigue? Now, the definition of alarm fatigue refers to the desensitization experienced by healthcare professionals. So all those who are working in the ward where the monitors are with these alarm sounds, whether they are nurses, they're physicians, whether they're assistants, all those people come into the bracket of healthcare professionals, including the primary nurses, due to the high frequency of alarm. This desensitization can lead to missed alarms, that is, you don't hear the alarms, or you just miss the action to be taken on it, ultimately compromising patient safety. Understanding alarm fatigue is crucial to implementing effective solutions within healthcare environment. So that was a brief overview. Now, types of alarms in healthcare. What are the different types of alarms that we are talking about? Now, recognizing these different types of alarms is very essential for understanding their respective impacts and management strategies. So only if all alarms are not the same, only if we know that what are these types of alarms, we can tackle them one by one and understand their challenges one by one, and also understand how to make strategies to overcome the challenges arising out of them. So the first kind of alarm is called the clinical alarms. The clinical alarms are those which are triggered by medical devices such as cardiac monitors or ventilators. To simplify it, these are those alarms coming up from the gadgets which are present in the ICU and in the step-down ICU or in the ER, and those which are connected to the ventilators. So these are called the critical alarms. These alarms beep or they are on when they want to indicate or when they want to trigger that something is going wrong with your patients. It is bringing the healthcare personnel's attention towards the patient. The second kind of alarm is non-clinical alarm. This includes the bed alarms, the infusion pumps, even the call bell systems which are around, whether it is a patient call bell system or it is any other type of call bells systems, any other kind of bleep you have in your surroundings in the critical care area. So all that which do not exactly tell about the individual patient's physiological change or his movement change, but all the other things which it indicates, this is the non-clinical alarms. Then what are the causes and contributors for these alarm fatigue? Identifying these causes is vital to mitigate the effects of alarm fatigue and enhancing responses to critical alerts. Now, the first is non-actionable alert. That means whenever there's an alarm which goes on or there's a bleep, there is nothing has to be done on it. That is called a non-actionable alarm. You just see it or you just hear it and then leave it. So that becomes a non-actionable alarm. The second is inconsistent setting. That means the setting of the alarm. That means when actually the alarm has been planned to, bleep, at that time it doesn't bleep, but it goes on bleeping unnecessarily. That is called the inconsistent setting. Whenever it is not required, or where, it is haphazardly bleeping. That is the inconsistent setting. And the third one is insufficient training. Training how to do the whole alarm management. That means, first of all, setting the parameters of it, whether the cables have been put properly or not, the electrode had been properly put or not. So those people who are working in the critical care areas and those who are responsible for handling these monitors and listening to these alarms, whether they are trained to do the alarm management or not, is again a cause and a contributing factor. So the causes are non-actionable alarms, inconsistent setting, and the insufficient training. Then, after discussing the causes, the contributors, and what these alarms are, let us discuss about the impact of alarm fatigue. What happens when there is alarm fatigue, and who are the people who are affected? Now, first, I would like to discuss that it has a very significant effect on the healthcare personals. Like I mentioned, the people who are working in the ICU setting or the critical care setting. Now, who are these people? They are the people who are spending the maximum time in these areas are, of course, the nurses. So the nurses are mostly affected by this. And a study which was published in PubMed, the study has been done in one of the Palestine ICUs. I could not get statistics for the Indian setting, but this helped me to just share that 63% of the nurses suffer from average to high degree of stress level, and 69.5, that means almost 70%, are suffering from high degree of stress level only and only due to alarms. I mean, if this is happening in some country, I'm sure it would be happening in our country also. Now, how do we assess this? That how they have derived to the statistics? There is a standard questionnaire called the Perceived Stress survey questionnaire. So it is the gradings are highly stressed, moderate stress, average stress, like that. So I think it's not a very big questionnaire. It has got different sections. So if anybody wants to assess the stress level in their own area, I think this is a good questionnaire which you can take, and it is a self-filling questionnaire. It is the perception of each nurse. They can fill it out themselves and submit it for this to collate that what is the assess the stress level in a particular group. Then how it affects the staff well-being and efficiency. The staff well-being and efficiency is greatly affected, and this can be seen by the stress and fatigue. What happens? It leads to stress and fatigue in the nurses. Because of this, what happens? There is sleep disruption, there is emotional exhaustion, and there is decreased personal accomplishment. When you're so drained out, what targets or actions you have planned for yourself, you do not get into those actions, and then you avoid it or you deny it, and then it leads to decreased personal accomplishment. So these are a few major reasons why the stress and fatigue also hampers our physical and emotional self. The second is anxiety and depression. Why anxiety? The constant fear of missing a critical alarm leading to accidents and errors. Now, when you are constantly on duty for 12 hours or 8 hours, you are going on hearing those alarms. Every alarm that bleeps, irrespective of whether it was a clinical alarm or a non-clinical alarm, whether it was because of inconsistent alarm, your ears your ears are hearing, listening to that, and you want to know that I hope I'm not missing out on a critical information. So in the view of being a patient listener to these alarms, when it goes on constantly bleeping, you become tired and you try to ignore the critical alarms, and this leads to accidents and errors. Now, how accidents happen? Accidents happen to the nurses. Suddenly, if there's a bleep goes, she is sitting and then she gets up. When she gets up, she hits her knee on the table. She hits her elbow on the corner. So these kind of small accidents are also accidents. We cannot ignore them. So these are an example of what I mean by leading to accidents and errors. Hindi mein there is a saying ke sher aya bola, and then actually when the sher came, um, people ignored and they fell prey. So like that, when the bleep goes on, bleeping again and again, and because of non-clinical errors or because of poor setting, it is actually not relating to a critical alarm or where you or to say an actionable alarm, then you kind of tend to just ignore and say okay, ठीक है बज रहा है बजने दो, it's bleeping, let it bleep. So because of that, what happens, you may ignore an indication, a trigger which the alarm was actually trying to say about the patient, where it needed your attention to do further attention assessment or to do a particular take an action towards any kind of a management for the patient, but you missed it. So when these type of things happen again and again, it leads to anxiety and depression. Now, it also leads to diminished quality of care because of this constant thing happening again and again, there is decreased attention. You try to ignore. You say, okay, it's bleeping. Let it bleep. I'll go after 5 minutes. I will go physically and check. Or, arey, wo to bach raha hai, bajne do. And because of we are not working alone, we work in a team. And one such statement or one such body language of ours has an effect on our colleague or our juniors or seniors, and then we are all humans. We tend to get influenced and we get relaxed and we actually ignore something which should not have been ignored. And it also causes something called a reduced situational awareness. This is an everyday scene. It becomes a routine that monitors are beeping here and there. So it becomes a routine, and any routine is not seriously taken, and it reduces situational awareness and slower response. We don't get up with a jerk, or we don't pay as attention as it should be. Decreased job satisfaction. Yes, of course. When all these things happen, we also have decreased job satisfaction, and we start questioning ourselves that are we professionally competent? Am I really, though we may not be sharing it with all or in our work area, but at least we will be talking to our best friend, to our family and friends, and to ourselves before we sleep कि यार मैंने सही किया क्या? Am I happy working in the ICU? Should I ask for a change? So all these so many questions come in our mind, and we keep asking ourselves. So this slowly gives rise to job dissatisfaction, and it leads to increased turnovers. So when somebody is resigning from the ICU, we the in charges or those who are in leadership positions have to also see that what are the underlying reasons why this particular person wants to get away from that particular area or the situation or whatever. So this is one of the causes why nurses easily get fatigued or trained or fed up working in places where there are monitors and gadgets which give alarms. Now, patient safety risks. Now, we discussed about nurses, how it affects the nurses. Now we discuss about the risks for the patient. You see, unless and until the nurse as a caregiver is not safe, or she is not comfortable, or she is not serious, how can the patient be safe? That's why I decided that first not to speak on the patient risk, but on the nurse's risk, and then speak on the patient risk. So addressing these risks is essential for maintaining high standards of patient care and reducing patient harm. Now, patient is at risk because we miss the critical alarm due to oversight. Because like I gave the example, sher aa raha hai, baj raha hai, it's continuously, bleeping, and it is bleeping for not valid reasons. So many times we try to oversee it, and oversight also happens because of it is not right in front of you. You are doing an important work, you are doing a sample labeling, you are doing documentation, you may be doing so many other things which are vital and which needs your focus on your nursing station table, and then suddenly this bleeps, but you think it is again a non-actionable alarm, and then it goes missed. So if this goes missed, it could have been a critical alarm, and there goes the risk towards the patient. So anything can happen to the patient. Then delayed intervention. Again, because you may think it is bleeping, and then slowly we get up and then go just to do what? Just to switch off the alarm. Many times I have experienced myself when I was working at the bedside, or when I go for rounds also, we see that the nurse has to get up just to go and put off that alarm which is bleeping and irritating everybody. So not only it is an extra energy consuming for the nurse, but it is also irritating for the patient who is trying to sleep, who has just been told by the nurse or the physician that his condition is improving. He is trying to sleep, he is trying to be positive and happy, and there goes the bleep, and then he says, "Arey, ab kya ho gaya? What happened now?" So that is one reason. And the nurse also thinking that, oh, the patient is fine now, the bleep, the alarm has gone on just because of some gadget error or some setting error. So she slowly goes and only tries to switch it off, missing out that it can be some complication arising in the patient, or it can be again some trigger or a warning sign which is being alerted to the nurse. Then many times it ends up into an adverse event. Of course, if you have a missed critical alarm and you have a delayed intervention, what is it going to give rise to? It is going to give rise to an adverse event. Now, those adverse events may be a patient fall, it may be a deterioration of the condition. And once there is deterioration in the condition, you know how difficult it is to bring back to the normalcy or to the previous normal status. And patient fall is an example. Like nowadays the beds with new technology and the modern beds, they have an alarm when the patient is moving. So when the patient is moving and the alarm goes, but you ignore it, and the patient falls down. So these are some example of adverse event which can happen, and these are the risks which are exposed to the patient because of faulty alarm management. And because of this, the quality of care given by the healthcare personnel, especially the nurses, and the patient outcome, it suffers. So the overall quality of care suffers, impacting health outcomes and patient satisfaction. So consequentially, it is crucial to adopt strategies that minimize alarm fatigue and promote effective communication among healthcare providers to enhance patients' care quality and operational efficiency. When we work in in our critical care area, we are doing a kind of operational duty, and the efficiency of that goes down if this topic or this subject is not taken care. Now we discussed all the problems. What are the risks which arises, the exposure to the patient and to the nurses. Now, how do we mitigate these strategies? Now, these strategies can be mitigated by very, very, deeply, or what I can say, the dire consequences can be managed if we approach this by a multifaceted approach. And the few of these strategies which is mentioned are also some evidence-based, are points which can be taken up as evidence-based practice in your own area. The first one is alarm customization. The alarms are put for whom? For the patients. So every patient is different. His condition, the way he responds, his vitals, everything is very different from a patient with similar condition. So therefore, the alarm for which, the monitor for which a particular patient has been assigned, that monitor's alarm should be customized according to the patient needs. So adjusting the parameters based on the patient needs and the volume, the tone, the duration, everything, if is customized according to the patient, it will be more beneficial. So when we are planning to resolve the issues arising, we should think of this customization. But there is a small, a challenge in this. This strategy needs a concerted effort to regularly evaluate, change, and update as per patient's condition. Whenever there is a patient's condition change, you have to go back and change the customization parameters what you had set. So it's a periodic task that you go back again and again and recustomize it. So in this, if you alone are not there, you alone are not in this, the other nurses who are, when you're changing shift, the other people who are collaborating in the care, those people also need to involve. Your biomedical engineers also have to involve. So just by saying customize is not enough. We also have to remember the maintenance part of it, that is, we regularly evaluate, change, and update the customized parameters according to the patient's needs. Then identifying the cause and taking timely action. Now, whenever there is an error in the alarm system, we have to assess for the cause and tackle it immediately, and not leaving it for some other time or postponing the action to be taken on rectification. So conduct regular audits for false alarms, malfunction, and inappropriateness. So everything has got a different meaning. Malfunction is different, inappropriateness is different, false alarm is different. So when we do audit, we should see that our audit points should be addressing all these variables. In this, again, like I said, we need to collaborate with the biomedical engineer. Also, interdisciplinary team is very important. Alone, we cannot do anything. So what does this interdisciplinary team do? This team sits together and we discuss, we meet, we conduct meetings to discuss, and we identify areas for improvement related to the alarm problem that is arising in our area. Okay, whether it is a part-time nuisance which you think is happening, or it is an interference to the calm atmosphere of your area, or it is actually not doing what it is supposed to do and harming the patient and the healthcare personnel, is what this group sits and discusses. And then it develops an action plan and it optimizes alarm management. So like any other team does, this interdisciplinary team, a few members come together to discuss about alarm management. And who are the members of the team? It can be the physician, the nurses, the ICU technician, the respiratory therapist, and the biomedical engineers of the unit. Now, physical setting and arrangement is also very important in this. When we are strategizing, nowadays, the corporate hospital, I'm sure, is involving the head of nursing to come and give her inputs, or they're taking her advice on how the infrastructure of the critical care area should be. So at that point of time itself, she can give her inputs to design in such a way that the noise is controlled and it improves communication. Not only the noise, even the vision, the visual aspect. Can you see the monitor? Can you, see the patient along? Nothing is coming in between. So you have a very, calm and pleasant infrastructure, so that these kind of problems don't arise later on. Infrastructure changes are the toughest kind of changes to be done later on. So therefore, right in the beginning, it should be told. Now, it is not only the responsibility of the head of the nursing, but even the the unit in charges, like the ICU in charges, the ER in charges, those people also, when any development, infrastructural development is happening, like any expansion is happening or any renovation happening, they can also give their feedback to the nursing head, and the nursing head can tell to the management, and this is how we can contribute to having uh, a beautiful environment where these kind of challenges are not there, or they are reduced. Then staff training and education. Staff training and education is also a very important strategy, or rather, a solution, or a component in the alarm management. How? Regular training and education related to what? Device function, alarm setting, troubleshooting, etc. So alarm management and best practices in handling the alarm management should be taken into consideration when we are doing on the job training, in service training, or whatever kind of training we are exposed to. Now troubleshooting is very important. Practically many places I have heard and even witnessed that don't touch the monitor will get spoiled, you people don't know how to handle, let the biomedical engineer come and handle, call him. So till we call the biomedical engineer or till he comes, the problem still arises. And when he comes, he just says, "Are itna chota sa tha, only the button was supposed to be pressed, or this needed to be tightened." So these kind of things he says. So these small, if we learn how to handle small things in the machine handling, the setting handling, it that is what is called troubleshooting, and there is no harm in contributing to this. After all, we are a team, we work in a team. So the training should include all these aspects. Then ensuring that all staff members are knowledgeable about the alarm setting, the response protocols, and the significance of the alarms. Now, what those parameters means, how you set those parameters, how you control the volume, there are different sounds in some, the latest technology gadgets, the alarms have got different sounds also. So if the sound is, goes beep, 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 and it beeps like that for 3 times, it means it is a critical alert. Okay, so a positional alert may be some other kind of a sound. So like that, the nurses should be trained what it means, so that she is not overwhelmed by these kind of alarms, and it also it reduces her fatigue. Nursing curriculum. Now, hands-on training with devices, how to do monitoring of the monitors, and the alarm management on the whole should be included in the nursing curriculum. Then, in the nursing curriculum does not mean our formal nursing education curriculum alone. It means our in-service education curriculum, in our departmental training curriculum, any curriculum, any kind of a training that we are imparting for ourselves, whatever is the name of that that education system. In that, one small subject should be alarm management, and not only the theory, it should also have hands-on experience with the devices, so that whoever is starting to work in this area does not is prepared that there is something called alarm, and there is a definition for alarm, and there is a lot of management and operational issues which goes around the alarms. So training and education can foster a more effective and patient-centered environment. And technology innovations. This is, the latest. There are so many forums which are asking for any innovations which has been done, or any study which has been done for advancing technology. So a lot of technology advancement has been done already, but still I would say that majority of our healthcare setting in our country cannot afford this kind of technology. So all the strategies mentioned above may not be fitting, or may not be applicable to all healthcare setting. Whatever suits you may be adopted, and those who can afford technology. Why this is hanged? Just a minute. This thing has got hanged.
Margaret, just stop sharing and share once again.
Okay.
Yeah, go to that slide that you were on, and then you can start the slideshow.
Sorry for that. Now, technology innovations, smart alarm systems. Nowadays, they call it, smart alarm systems. They are differentiate between critical and non-critical alerts. Remember, in the beginning, I had said the types of alarm, the critical and non-critical alerts. So these smart alerts very clearly differentiate between the critical and non-critical alerts. Also, they integrate the alarms with the electronic health record, and these are also displayed in your central monitoring system if you have. So this integration is called the smart alarm systems. Some companies have got monitors where this system is embedded, and it is also available and set up in many of the advanced hospitals. It also helps streamline communication and facilitate timely intervention. Of course, if we have all these facilities, communication will be very effective. If it is recorded in the electronic health record, maybe that information goes directly to the physician and he knows something is going wrong, and he takes action, or he advises action to be taken to the nurses. And in all this process, we save time. And embracing technology innovation in alarm settings can greatly enhance patient monitoring and reduce alarm fatigue. And this is what the main objective is, that our monitoring system, in which alarms have got a vital role, should help us to improve the patient care quality, the patient outcome, and reduce the fatigue of the caregivers. Now, all these strategies stated so far are significantly used to reduce non-actionable alarms and improve the focus on critical alerts. Then implementation and continuous improvement. Now, these strategies which we discussed earlier, they have to be implemented in our own areas. Now, like I said, all areas are not the same. We have different healthcare settings, we have different environments, our scope of each critical care area is different. So one type of implementation may not be the same for everybody. So what is the way out? How do we know, how do we assess what is the right way in our area? So the best way, which I thought was, and thanks to madam also said, Tanka madam said, go ahead with this. So therefore, I thought the PDCA project approach would be the best and also the easy way for us nurses. In this PDCA, that's the Plan, Do, Act approach, we do the planning of interventions. First, you assess, you do a planning. What are your problems? How, what intervention should be done? So complete, create a blueprint of what is happening. And then you implement the changes, and then you monitor the results, and then necessary adjustment to ensure continuous improvement in alarm system, and the performance and the workflow of the staff can be monitored. So now let's go one by one and see how this can be done. Now, the first step is the plan. In the planning, you first make a problem statement. That is, what is your problem related to alarm management? Nurses are experiencing alarm fatigue due to frequent non-actionable and false alarms from monitoring devices. This leads to desensitization, delayed responses, and potential patient safety risks. This is an example of a patient's problem statement. So this whole thing is an example. You can replicate it, or you can change it according to your area. Your area is very different from others. So this is an example of a problem statement. Then you have to set objectives for the project. Now, what are going to be the objectives? The objectives can be reduce non-actionable alarms by 30% within 6 months. So again, this is just a vague figure, 30%. It can be for, if it's more challenging, it can be 60%, 40%, but some figure you give to yourself so that you have something to aim towards within a time frame. 6 months, 3 months, or whatever is the time frame, you can set an objective for that. Improve nurses' response time to actionable alarms, enhance patient safety and satisfaction. So these are the objectives that you want to set for the project. And then how are you going to do the analysis? The analysis can be done, or the problems can be brought into like one page or in a particular framework by doing a fishbone diagram, problem identifying. So the identification can be equipments, that is poor alarm settings, setting of the poor limits of the alarm, outdated monitors, default setting, any fault in the machine. Then the people, lack of training, overworked nurses, overload of working, long working hours. So all these can be the problem related to people working in the area. Then process. There is no SOP related to alarm management, or what is supposed to be done when an alarm goes on or off, or there's a continuous non-actionable alarm. So if there is no SOP, that can be a problem. So that can lead to an inconsistent handover. So that can also be one of your problems. Then also focus on the environment, high patient acuity, noisy ward environment. So the alarm voice is subdued because of some other voice in the ward. So that root cause analysis can be presented in the fishbone diagram. Then you also propose intervention in your planning stage itself. You review and customize alarm limits per patient condition. Like earlier said, it should be according to the needs of the patient. Implement staff training. Introduce a tiered alarm system, that is critical versus advisory. Critical alarms is you need to take immediate action, and advisory, like for example, you say that it is asking you to continue the monitoring or observe very closely for a few more period. Then regular audit of alarm logs and device setting. So you have to create audit parameters, audit forms to monitor the device setting. Then develop a standard alarm management protocol. So this is all that goes in your planning stage. This is an example of a fishbone diagram, that all your problems related to measurement, material, people, process, machines, environment, and then ultimately it leads to the alarm management problem. So this is how you can present your problems. Then the second one is the implementation part. So you plan that you are going to implement this for a period of 3 months. What you do, you select one ICU or a particular area, ER, ward, wherever there are monitors, as a pilot unit, and then you train all staffs on new alarm protocols. You reconfigure devices with patient-specific alarm thresholds. You collect baselines and ongoing alarm data, that is false versus true alarms. You have to collect how many in a shift or in a day. You collate everything and you get over 24 hours how many false and true alarms were there. And then you monitor nurses' feedback via short weekly survey. So what they feel about, you have a set questionnaire which they need to fill. So this is what is a sample of a pilot implementation activity. Then you also do the check. In the check, that's the third stage of the PDCA cycle. You do a data analysis. Whatever data you collected from your log forms, from your audit paper, from the nurses' feedback, all that you compare the alarm frequency, the types before and after an intervention. You track the number of non-actionable items. You monitor patient safety indicators. That's the missed alarm, adverse event. You collect nurses' feedback and the response time. Then the result review. Was the 30% reduction target met Earlier, you had set a target of 30%. So was that met or not? Did the nurses' satisfaction improve or not? Any unintended consequences happened in spite of all this? Were there missed alarms? Was there increased workload? So all that is going to be depicted in the result review. Then the fourth is act. In the last stage, you analyze or you give a report that whether this project was successful or not. So the rollout intervention hospital wide, you if it was successful, you have to roll out all over the hospital. Yes, it was successful, you take approval of your authorities, and then the same kind of implementation has to be done across the hospital wherever there are monitors. And you update the hospital policy on alarm management. You integrate alarm customization into the nurses orientation program, and also maybe in the other kind of training that you do for your critical care area personnels. If it is not successful, supposing you did not achieve what you had said, the goals that you had set, what do? You reassess the root causes, you refine the training methods again, and you adjust the alarm thresholds again, and you plan another PDCA cycle with modified strategies. So you have to, re-strategize or remodel the whole project, and then repeat the project at another time, maybe this time in a different setting. So this is how, when you do a PDCA project and you have the results, and if you're successful, it is a great achievement, and then things will surely improve. And it is not successful, no problem, you do it again. Maybe this time you do it in a more refined manner, and you will get certainly a better result. So this is one way how you do the implementation of the strategies that you are planning. Remember that integrated team, that team which has got all personals, from the physician to the biomedical engineer, all of them can sit together and brainstorm on the outcome of this and see that how this is going to be beneficial for the patient as well as to the nurses and the other healthcare personals, and then take it forward as a new SOP or a policy in your hospital to control alarm fatigue. And let me tell you, alarm fatigue is not only for the nurses. Of course, the rate of fatigue and the rate of risks and the consequences is higher for the nurses, but it also affects the physicians, the ICU intensivist, and the other people, even the biomedical engineer. He has to come again and again. He's working somewhere. He has to come again and again. So it affects everybody. So everybody is fatigued and everybody is demotivated when they are called for unnecessary tasks. So it is not restricted only to nursing. It is a teamwork, and we must ensure that everybody has a safe place to work and achieve our objective of safe patient care delivery. So addressing alarm fatigue is paramount in improving both patient safety and staff well-being. By implementing evidence-based practices, leveraging technology, and fostering collaboration, healthcare facilities can reduce alarm fatigue and enhance overall care quality. Continuous evaluation and adaptation of strategies are essential for ongoing success in this imperative endeavor. So thank you all. If there's any question, please let me know. And these are the links which I said, the study that I have mentioned, it is from this. So thank you all for patiently listening, and I'm open to questions.
Thank you. Thank you, Margaret. Very, very good presentation. Maybe you can stop sharing. And I would, before we take the questions, I have two short videos to show to our people. I just found them in the YouTube. So just, it's a very short video. I would like you to hear the different alarms. It's very important, those who have not worked in the ICU, it is, it may not be even, you may not be able to even imagine what kind of chaos can happen to the brain. I spent 16 years in the ICU. So I used to go home days when I sleep, the alarms will be ringing. In my sleep, the alarms are going on. It used to happen very frequently because I started working in 1980. The alarm fatigue terminology came much later, but I worked in the Middle East, so the personalization of the alarms started happening while I was there. So we learned it. So that was a policy in our ICU. So there are questions, there are comments. We'll take them in a minute. Just give me a second so that those who are new to ICU, you can, though this is the monitor alarm, okay, just pay attention to the different tones that are coming, okay? Now this is warning, SPO2 low. Now there is desaturation. So that's one, okay, and the other one is a little bit on the
There are a few
ventilator.
different types of alarms which might go off on the ventilator. The same noise might sound for different issues, and you will need to look at the ventilator to work out what the problem is and what to do. For example, this is where you would look to see if there has been a disconnect in the patient or if the O2 supply has failed. If you are unfamiliar with a ventilator and looking after a mechanically ventilated patient, don't worry. Anything that goes wrong can seem quite scary, but if you stick to a calm, logical and methodical approach, you can resolve a lot of problems. As ever, the approach you'll take will be in the ABC format. A, check the airway. Is this a simple problem like the ET tube has become displaced or disconnected from the ventilator? B, breathing. Increase the inspired oxygen to 100%.
So
And check the measured
so
FiO2
I'm going to
ventilator.
stop the video because we have crossed our time. So I just wanted to, all of you to experience the kind of alarms that can literally be going crazy in the ICU. So alarm fatigue, the word comes because already Margaret mentioned desensitization. When that happens, you may not react to something and it can actually kill a patient. And I have had at least two, three incidents in my career where I have seen someone got late in responding. And when I was working in Fortis, one of the common complaints the ICU doctors used to come and tell me was that, Tankam, please do something about them because they just switch off the alarm without checking. That is one behavior of alarm fatigue because you are hearing it so often. So you go and just mute the alarm without checking what's happening to the patient. So here somebody mentioned that, Sunita, that wonderful session, but customization, it would be more of harm as compared to safety as being critical care nurse. So here, Sunita, my advice is that, you have to, the policies around how do you personalize alarms. So you sit with the intensivist and you decide. You're not going to personalize alarms, every hour or something. It's not like that. When we started with this trying to personalize the alarms once every shift. So when we take the handover, the protocol was very clear, 10 percentage up and below, so that all the parameters were set, given by the intensivist as a policy and signed off. The nurses only had to go and set the alarm, and it was double checked by the shift in charge that it was done well. And in between, if patient's condition changes for any reason, only the shift in charge had the authority to personalize the alarm. Otherwise, the assigned nurses were only allowed to do it at the beginning of the shift. So that kind of ensures that, everybody is learning, somebody is checking, so that we are not, so saying that parameters are set according to patient condition is not the policy. The policy has to be very, very clear. What is the percentage? If someone's heart rate is 100, running at 100, when would I like to hear the alarm? Would I like to hear it at 110 or would I like to hear it at 120? or would I like to hear it at 40, or would I like to hear it at 60? So there is a lot of thought process that goes in behind personalizing an alarm. So that's not something part of this today's webinar. Today's webinar is about understanding how alarm fatigues can happen, and we should be aware of it, and then we should take action. And we don't have to take the action alone, because you need the intensivist, you need the biomedical engineer. And with advanced technology, Margaret did mention analyzing all the alarms. It's pretty easy. At the back end, you just have to ask the biomed. They will give you the entire chart stating that what kind of alarms happen. Even so many years ago, when I was working abroad, I was able to get that report from biomedical. And many systems inside each individual monitor, you can go back and check what all alarms had happened and what was the event. So we used to do root cause analysis on the ventilator. If the intensivist find that there was something that was not observed right, so at the bedside we can go back and look at the history. And I'm very sure that many of you who are in the ICU will appreciate this is what can be done, you know. Many are saying excellent presentation. Thanks, Margaret, for that. So I'm looking for questions. Someone mentioned about the artificial intelligence. I'm very sure that that will definitely come into play as time goes. You know, it will make life more easier for all of us. But please understand, you know, AI is very easily used by everyone. But we need to be partner. We need to understand. Even today, there is a lot of intelligence already in those machines. So many years ago, when I got into critical care, many things I learned from the biomed. I had to call them and ask them, how do I find out? How do I find out? I wanted to know whether patient had non-sustained VT which was missed, because nurse will not report she missed it. It was a non-sustained VT. So we could go and, you know, actually check that. So what is that? Alarm fatigue is small problem, but now it becomes a big problem to nursing personnel. We have to come over it. It's a very new topic to me. Yes, there is no name, but this is definitely not a new problem. It is a very old problem. We are talking to someone who has been in critical care from 1980, and I spent 16 years, so it is not a old problem. It's a new problem. No, sorry, it's an old problem, but with a new terminology. Only that time we did not call it as alarm fatigue, but we knew that it was playing havoc, because there was a tendency for nurses to miss the real alarms. Okay, so I'm trying to see if there is any question. Another danger is alarms are kept on mute, avoid disturbances. Definitely, Kamaljeet, that is definitely something that we should see. The alarms being mute is because it is not being customized. It's troubling us so too much, so we just mute the alarms, which is very, very dangerous. And you know, we have so many things to do for our critical care patients, and putting an alarm on mute is definitely you're taking too much risk. We have given competencies to mute alarm is for critical care consultants and nurses in charge and shift in charges. Okay. So nobody can mute alarm. That is what it means, you know. See, alarms must be investigated. You can mute the alarm only once you have investigated and found this is the reason for the alarm. So the policy will say that who, what. I'm not going to say how the policy should be written. That is for each organization to decide. If you have enough doctors and everyone to actually go and mute the alarms and figure it out, yes, why not? I personally, we had to train our nurses that when are they allowed to mute the alarms. So that is a whole lot of, you know, being in clinical settings I experienced, but these consequences was not fully aware of it. Okay, okay. Thank you. So is there any system that we can get record of false alarms? Yes, yes, yes. If you ask your biomedical engineering guy, he will give you the complete report. And I'm very sure now it is far more advanced. So you will come to know all kinds of alarms, whether it is false, critical, or advisory, or you know, total threatening. So that all is possible. Is there a
It comes under the heading of smart alarm systems. If
Yes.
that is in the monitor, then they can get all the records.
You can just ask your biomedical. Alarm fatigue record was kept for patient safety, come under the quality indicators. Uh, how do you define alarm fatigue, but then how do you quantify alarm fatigue? That's not possible, Akshay. You cannot quantify alarm fatigue. The all the missed alarms, or any too many of those unnecessary alarms, all would only prove that there is a possibility of alarm fatigue. So how did you keep an alarm fatigue record? I don't know. I am little lost. If you
Ma'am, may I answer that question?
Yes, yes, yes.
There is a standard questionnaire which is called the perceived safety study questionnaire, so that you can give it to the ICU nurses or whoever you want to give, and they will answer those questions, and then the grading can be done whether they are highly stressed or moderately stressed. So that's one small way how you can get your assessment of the grade of fatigue judged.
But obviously you cannot keep a record of that, right? You
Yeah.
cannot keep a, I mean, you have to do a periodic assessment to see,
Yes.
are they, stressed because of the alarms. That's how interpretation would be. So then, ma'am, can include alarm fatigue in HERA. That's up to you. Yes, you can use any modality. You can use a FMEA format to see that, if alarms are not set, what can happen, what is the, so PDCA is the format Margaret discussed. That is one way of doing it. Within that, you can do a proactive analysis by using a FMEA, and you can also use HERA to say that how big is the problem, or how risky is the problem. Sometimes nurses just don't attend the alarm, maybe because, yeah, that's exactly that we are talking about. Nurses are not attending the alarm because there are too many alarms. So then they are just used to it because it is ringing. The music is in your ears, so you are able to do that. Okay, so thank you, thank you, thank you, thank you. Did we miss any question? Please feel free to unmute and ask so that we can answer any questions. Thank you so much, Margaret. That was very well explained. And I am thinking that, yes, maybe something more we need to do around alarm fatigue, maybe in the next round of cohort. I don't know. So one of them might do a project around this. There is a possibility, yes,
I
because
thought that you will say that.
yeah, yeah, because I always think, you need to do something. The knowledge is good enough.
So,
Maybe you are the one who is going to mentor, so maybe whoever is your mentee may be able to do that, because it's very nice to get into the depth of things and try to understand, and all of us will learn from that, right? What did the biomedical had to say about the AI or whatever it is? What kind of report came out? Maybe we are not even fully aware of the capabilities of the machines that we have, because this is something I learned when I was exposed to some advanced equipments once I went to Middle East. Okay, so when I started, I was a very curious nurse. Every time I have 100 questions, so I kept on asking, and the biomedical came and told, who is this new Indian nurse who has landed now with so many questions? Believe me, the more I asked, the more answers I got and we learned. And we were able to do some very good, safety measures even those days. I think today's, it should be even more easy for you to do that. So thank you everyone, and feel free to stay connected with Margaret or me if you are interested in this topic. And we are also very keen to know what are you doing in your, or so please go back and look at your machines a little bit more closer and see if there's something that needs to be done. And the protocol cannot be written only by nurses, so please understand that. You have to sit with the intensivist, you have to involve the biomedical before you write down, and every ICU will have their own, customized, protocol, because based on the speciality, you will have to write it down, and it's not very easy. It's pretty complicated to write down a protocol on, customizing your parameters. Now, with more parameters available on a monitor, it becomes even more complicated. How are you going to personalize those alarms? But it's worth learning, and it is worth implementing for the safe care of our patients, and also for your own ears and brain. Otherwise, you will have the problem I had. When I'm sleeping, also the alarm is, going on in the sleep. I don't know whether any one of you experienced that, but I had that for years together, when I was ICU nurse.
No, very true, ma'am. I must confess that when I was doing this presentation, I went back to my CTVS ICU, and I started my career from there. And the accidents which I wrote here is truly when I was new, because CTVS ICU is such a serious place, and they create a big aura around it that it's a very serious place. And whenever there used to be a alarm goes on, I used to get up in such a jerk. I used to hit my knee, on the corner of the table. So these kind of, and to an extent that one of us, I surely remember that one girl fell also in the process of running. So the distance from one bed to another also is a factor that running from here and there also causes stress, ma'am, and fatigue. So you rightly said that if we take up as a project, more awareness will rise towards this topic, and it would be a very good idea to present.
Yes, yes, because there are many consequences for the nurses, and sadly, if it's something happens to the patient, sometimes they are not even retrievable. It's like a permanent harm that has been done to the patient, and we carry those burden for our entire life. Dr. Neeta, you came on the video. Do you have something to share? Okay, I think that's it. So thanks a ton,
Thank
Margaret.
you, ma'am.
And we'll
Thank you,
see
ma'am.
you all in September once again with another safe learning session for safer care of our patients. Thank you, everyone, and take care. Shabak khair.
Thank
Good
you,
night.
ma'am. Good night to all.
Okay, bye bye.